Greetings to all the PhysioTV viewers. Today, we bring you yet another interesting talk in our entire gamut of talks which are there on PhysioTV. PhysioTV is a free YouTube channel which is for the physios, by the physios, and we bring you content from all over India as well as all across the globe from distinguished speakers and therapists. Today, we are joined by Dr. Dharmang Vyas, who's a bachelor's from Ahmedabad and a master's from Vadodara with specialization in musculoskeletal and sports physiotherapy. He's an assistant professor in the Parul Institute of Physiotherapy, Parul University, Vadodara, and is awarded 5 times with Academic Excellence Award by the Parul University itself. He has done his 2-month certification course in manual therapy from the Capri Institute, Delhi. And he also is a coordinator for a 3-month fellowship program, which is conducted in Parul University on shoulder and knee rehabilitation. He has more than 10 international publications in peer-reviewed journal and also has 2 patents to his credit, one of which is in process. He is a distinguished speaker and has managed to be eligible for a SSIP grant from the government of Gujarat, as well as a product development grant from the Parul University. I welcome Dr. Dharmang Vyas today to enlighten us on a very interesting topic on anatomy integrated rehabilitation or anatomy integrated biomechanics of the shoulder girdle. It's a very different topic, and I guess because Sir is already conducting a fellowship program, I'm sure the listeners are going to get a lot of pearls of wisdom from Sir. Over to you, Sir.
Welcome all to PhysioTV. Thank you so much for inviting me, Sona ma'am. And let's start the session without wasting any further time. So when we talk of biomechanics, we usually study the anatomy as well, but we don't go into the depth of the anatomical connections in correlation with biomechanics. So we always, as a bachelor's of physiotherapy, we always study about anatomy separately and biomechanics separately. And when it comes to biomechanics, we do study about some amount of the components of anatomy, but we do not exactly look into the connections between the anatomical structures or the anatomy and the biomechanics. So today we are bringing you a topic where we are going to talk about the integration of human anatomy into human biomechanics, specifically for the shoulder girdle. So what do we understand by biomechanics? So biomechanics is a term that studies about the structure and function of biological system, which includes how bones, tendons, ligaments, and muscle work together through means derived from mechanic methodologies, being its main objective to improve performance, to prevent injury, and to enable rehabilitation. So as physiotherapists, our main target is to prevent injuries and to have a better rehabilitation and to enhance performances when we talk of sports person. So biomechanics is a very important component of rehabilitation or a physical therapy protocol or program where we need to integrate these biomechanical concepts to improve our rehabilitation outcomes, to prevent injuries, and to improve the performance of an individual as an athlete or an active sports individual. So let's begin with the session. We are going to talk about anatomy integrated and biomechanics of the shoulder girdle. So quickly we'll go through the superficial anatomy of the shoulder girdle. What you see here is the X-ray of the shoulder girdle, right? Where we are going to talk about the bones that can easily be visible on an X-ray. So we see the scapula, the dotted lines that you see around in the image here. These are the border lines where we have the scapula, right? You can clearly see the markation on the X-ray where we have scapula on the right side. We have the head of humerus, which we see here, right? And we have the shaft of the humerus and the ribcage. What we see here is basically the tibial tubercle, and here this is the lesser tubercle. Now these two structures are important because when we move ahead with the session, we will see that how do we integrate this anatomical structures when we are talking about the biomechanics or notions around the shoulder girdle. So the scapula, there is the anterior and the posterior view. We can see some of the components of the scapula as well, the supraglenoid tubercle, the coracoid process, the glenoid cavity, the inferior glenoid tubercle, subscapular fossa, lateral border, the medial border, the inferior angle, spine of the scapula, the supraspinous fossa, superior angle, acromion, coracoid process, glenoid cavity, lateral border, and the infraspinous fossa. Now, a lot of these anatomical structures that you see in the scapula are an origin or insertion for major muscles around the shoulder girdle. As we know that scapulothoracic joint is not a true joint, And all the movements that occurs around the scapulothoracic joint is primarily brought about by the muscles that connect the scapula to the thoracic wall, to the spine, as well as the humerus. Here we have the anatomical structure of the humerus, where we have the deltoid tuberosity, the surgical neck, the lateral and the medial epicondyle, the trochlea, the anatomical neck, head of the humerus, the greater tubercle we were talking about, and the lesser tubercle. We have the intertubercle groove. Okay. Then we have the lateral supracondylar ridge. Coming to the clavicle, we have the acromial and the sternal end. We have the shaft, the deltoid tubercle, where we have the attachment for the deltoid muscles. Conoid tubercle, subclavian groove, trapezoid line, and tuberosity for coracoClavicular ligament. So why is it important for us to understand the anatomy of head of humerus or the humerus, the clavicle, and the scapula together is because when we talk of shoulder, we do not talk of one joint. We talk of the shoulder girdle. And shoulder girdle basically is made up of sternoclavicular joint, acromioclavicular joint, the glenohumeral joint, and the scapulothoracic joint. So in no case, we can separate acromioclavicular joint and sternoclavicular joint from the shoulder girdle. Though they are very small joints, they do not have cross motions at these joints, but these are a very, very important part or components of achieving full range of motion or achieving proper functions of the shoulder as a whole. Here we have the whole shoulder girdle, what we are talking about, which includes your sternoclavicular joint, which includes the acromioclavicular joint, which includes the glenohumeral joint, and which also includes the scapulothoracic joint. Out of these four joints, the acromioclavicular joint, the sternoclavicular joint, and the glenohumeral joint are true joints, or we can call them as synovial joints, which have capsules and the synovial membranes. The scapulothoracic joint basically is not a true joint. It is only the attachment of the scapula on the thorax by the muscles that functions around the scapulothoracic joint and the scapulohumeral joint. Basic movements. We are very much familiar with basic movements: flexion, extension, abduction, adduction, and internal external rotation that are occurring around the shoulder girdle. Now, coming to the main component, the shoulder complex is composed of clavicle, scapula, and the humerus, is an intricately designed combination of three joints linked to the upper extremity of the thorax. Now, resting position of the scapula. This is important because in a lot of cases, we may have some amount of scapular dyskinesia, which we call as the abnormal motion of the scapula or malposition of the scapula, which can cause a lot of problems around the shoulder girdle. So coming to the important component is how do we analyze what is the resting position of the scapula? Okay. So when you see the scapula from a posterior view, it is 2 inches from the midline between the second and the seventh rib. So the whole of the scapula lies between the second rib and the seventh rib. So that is the span or vertical span of the scapula. There is mild internal rotation of the scapula, that is 30 to 45 degrees from the coronal plane. Anteriorly tipped, which has 10 to 20 degrees from the frontal plane, and upward rotated scapula, which is 10 to 20 degrees from the sagittal plane, that's here. Right. So this is basically the resting position of the scapula. If you see from the superior view, this is what we were talking about. I'll just move to the previous slide. Right. The internally rotated 30 to 45 degree from the coronal plane, what we can see from the superior view. If you see the image 1 or A, you can see that the scapula is slightly anteriorly rotated in the coronal plane, which is around 30 to 45 degrees. This is what we see as the anterior tipping in the second image, right? So there is a 10 to 20 degrees of anterior tipping of the scapula. So scapula is slightly oblique. It is not vertical, right? So if you see this is slightly oblique, what we call as the anterior tipping of the scapula. Now coming to scapular motions, we will focus a little more on this slide because we are going to talk about a lot of muscles around the scapula. This is what basically anatomy integrated biomechanics means, that we do understand that the motions of the scapula occur on the thoracic cage. We do understand that glenohumeral motions are associated with scapular motions. But integrating anatomy means that how does this muscles around the scapula bring about motions that occur at the scapulothoracic or the acromioclavicular joint or the sternoclavicular joint and the shoulder girdle as a whole. So talking in general about the motions around the scapula, we have elevation, we have depression, we have protraction, and we have retractions. So these are four main components of these scapular motions. Along with that, we have the upward rotation of the scapula. We have the downward rotation of the scapula. And then there is anterior tipping or tilting and posterior tipping. Okay. Go back to the previous slide. We have already discussed what is anterior tipping here. So similarly, we go for anterior tipping or posterior tipping. So primarily we have 8 movements that occurs at the scapulothoracic joint. That includes elevation, depression, protraction, retraction, upward and downward rotation, and we have is the anterior and the posterior tipping. Now coming to the second image, how does this motion on the scapulothoracic joint occurs with the help of the muscles? Now we will be talking of a term called as force couples. We will be using this term very frequently, so please pay attention on force couples. What are force couples? Force couples are the combination of forces produced by a particular group of muscles in order to create a specific motion around the joint. I'll repeat that force couples are the combination of muscle forces that comes from different group of muscles to create a particular motions around the joint or around the bone. So when we talk of upward rotation of the scapula, that occurs with the glenohumeral motions. We have all read about scapulohumeral rhythm. Scapulohumeral rhythm says 2:1 ratio, that when your scapula moves by 20 degrees, when your humerus moves by 20 degrees, your scapula has to move by 10 degrees, right? So 2:1 is the normal ratio for the scapulohumeral motions. So how does this motions around the scapula occur along with the humerus? So when the humerus starts gliding up, okay, it is the upper fibers of trapezius that you see here. It is the serratus anterior to some extent. And along with that, it is the lower fibers and the middle fibers of trapezius that creates upward rotation of the scapula. So in order to have a better scapulohumeral rhythm, you need to have good coordination of the muscles, that is upper fibers of trapezius, the middle and the lower fibers of trapezius, and the serratus anterior. When these three muscles contract together in a given specific time, okay, this creates a smooth upward rotation of the scapula. Now the humerus moves because of the deltoid and the supraspinatus. So as soon as this humerus starts moving, the three muscles that we saw, that is the force couple between the trapezius and the serratus anterior, allows the scapula to slide upwards and rotate laterally to create the motions around the shoulder girdle. Opposite to that, the rhomboids and the rotator cuff basically tries to pull the scapula and the humerus down, right? Creating retraction of the scapula. Now, how do we integrate this into our rehabilitation? We'll take a simple example of frozen shoulder. We all have seen that when we talk of motions around the frozen shoulder, when we try to elevate the humerus, scapula elevates first. Now, what happens in this case is there is an overactivity of the levator scapulae and the upper fibers of trapezius, which creates elevation. So in all of these cases, when we talk of motions of the scapula, the trapezius creates elevation, right? Trapezius creates elevation, right? Now, if the trapezius are hyperactive, they will usually create elevation when the patient tries to do abduction. So with abduction, it always tries to create elevation. And this is an abnormal scapulohumeral rhythm. Now we need to restore the normal scapulohumeral rhythm in order to have a smooth motions of the humerus. So what do we need to do is, we need to start activating the trapezius, the serratus anterior, and the upper fibers of trapezius. And we need to start releasing the muscles which retract or pull down the scapula, that is primarily the rhomboids, and to some extent it is the latissimus dorsi. Because the attachment of the latissimus dorsi is at the inferior angle of the scapula, it tries to pull the scapula down. So latissimus dorsi being a very strong muscle, it is a large muscle, right? One of the attachment is at the humerus, the other attachment is at the inferior angle of the scapula, which basically tries to pull the scapula down and retract. So what is the action of latissimus dorsi? It pulls the hands from full flexion down behind the back with internal rotation. And that is why we call it as a swimmer's muscle. Basically, it is needed to do the action in the swimming. That is, from full flexion, it comes down into extension, hand goes behind the back and internal rotation. Now, latissimus dorsi being a very strong muscle, if it is tight or if there is a, we can say, inactivation of the latissimus dorsi, or if we say that the latissimus dorsi are hyperactive, Okay, because a lot of shoulder cases which come to us after fracture or injuries are immobilized. So when they are immobilized, the latissimus dorsi is constantly in a shortened position. So this does not allow the scapula to move up. So in those cases, we need to activate the trapezius, the serratus anterior, the lower fibers and the middle fibers of trapezius. But along with that, we need to start releasing the rhomboids because they don't allow the scapula to protract and move upwards. Along with that, we also need to release the latissimus dorsi, which comes and attaches on the inferior angle. Why? Because this pulls the scapula down. It does not allow the scapula to move up and elevate or move upwards. So combination of all of these muscles together, specifically the trapezius and the serratus anterior, what we call as a force couple, allows the scapula to rotate upward and elevate during the motions of the arm, which brings about the normal scapulohumeral rhythm. So here again we are talking about some of the muscles that comes with the motions of the humeral joint, right? So what we do here is we will just understand that how does the muscle function, right? So what does the serratus anterior do? They create upward rotation along with the pectoralis minor. So this is the anterior view of the scapula. How does the serratus anterior go, right? Causing protraction. So serratus anterior and pectoralis minor here causes protraction. The middle fibers of the trapezius, the rhomboids and the rhomboids major, they usually bring the scapula into retraction, okay, closer to the medial border or closer to the spine of the scapula. The levator scapulae and the upper fibers of trapezius causes elevation. So here what we are talking is, we are talking about the action of muscles which creates isolated or individual movements at the scapula, that is elevation, depression, protraction and retraction. Okay. And then we will see how does the combination of all of these muscles create upward and lateral rotation, right? So what do we see here again is that there are different muscles which create separate motions at the scapula. Coming to depression, latissimus dorsi, which we were talking about, is a strong muscle, tries to pull the scapula down. If this muscle becomes tight, okay, or hyperactive, this will not allow the scapula to elevate or move upward into rotation. Then you have lower fibers of trapezius, which also brings the scapula down. And we have the pectoralis minor, which also causes the depression, right? So now, patient who does not have proper elevation or scapulohumeral rhythm or upward rotation of the scapula, we understand that apart from abnormal motions, we have these three muscles which primarily depresses the scapula, and other three muscles here, that is levator scapulae, rhomboids minor and major, which creates medial rotation, which does not allow the scapula to rotate upwards. If we hold it down from this side, okay, so it is like one is pulling down and the other is trying to pull it up. Now, what happens is that the muscles that pull it up, specifically the upper fibers of trapezius, the serratus anterior, okay, and to some extent the levator scapulae, right, lower fibers of trapezius, right, okay, all of these muscles, they try to pull the scapula up during activities, but there are latissimus dorsi, lower fibers of trapezius, rhomboids, major, minor, which are very strong, which pull the scapula down. So every time I try to do the movement, what happens is this muscle does not allow the scapula to move up and rotate laterally. So that creates more of elevation. And every time I do this, my upper fibers of trapezius are becoming more and more hyperactive. Okay, so they are becoming more hyperactive. So then they create more of elevation rather than creating rotation along with the combination of serratus anterior. To all of this, what is added is the weight of the limb. So we also have the weight of the limb here, right? And what causes upward rotation is the serratus anterior, mainly the lower 5 digits, upper fibers of trapezius and lower fibers of trapezius. And this is what we call as force couple, right? So it is very important for us to have this force couple to have a normal upward rotation and elevation of the scapula during the motions of the humerus. And this together creates a normal scapulohumeral rhythm around the shoulder joint. And that is why we considered this topic as anatomy integrated biomechanics, because when we consider about the muscles that create around motions and how does this muscles work to create a normal motions around the joint is when we talk of biomechanics. So scapular movements in relation to the glenohumeral joint. This is what we were talking about, the normal scapulohumeral rhythm. At a resting position, this is where you have your scapula and this is where you have the humerus. Okay, and this is the acromioclavicular joint. Now, I would like you all to pay attention here because what we are seeing here, we will correlate it in the coming slides where we talk about conditions like impingement, that is subacromial impingement, or can be subacromial bursa, irritation, it can be the rotator cuff tendinopathies. How do they occur and what needs to be done in such cases? So we'll quickly just throw some light on that as well during the session. So what happens is that when the scapula or the humerus starts moving up, okay, say for example, the scapula has moved by 60 degrees. Sorry, the humerus has moved by 60 degrees. The scapula has to move by 30 degrees. Once the humerus moves by 120 degrees, the scapula moves by 60 degrees. And the combination of this 120 along with scapula 60 degrees of motion or upward rotation creates a full 180 degree of abduction or flexion at the shoulder girdle. And that is why we consider it to be a shoulder girdle, because you can never have isolated motions of glenohumeral joint without motions of the sternoclavicular joint, acromioclavicular joint, and the scapulothoracic joint. In a lot of cases with stiff shoulders, what we prefer doing is we only work on improving the range of motion or mobilizing the glenohumeral joint. We do not put any focus or any treatment programs which allows the motions or to improve the motions of scapulothoracic joint. We do not work anything to do with the acromioclavicular joint. We do not do anything with the sternoclavicular joint. And that is why in a lot of cases with stiff shoulders, it can be post-operative stiffness, it can be frozen shoulders, we do not achieve a full range of motion because our maximum focus is only and only on glenohumeral joint. Whereas in a lot of cases, like impingement, like you see here, this is the resting position. As these glenohumeral joint starts moving, the scapula has to move, and acromion is connected with the scapula. So along with the scapula, the acromion also has to move. So what happens is throughout the range of motion of the shoulder joint, there is some space. We are not able to see here, but in the next, we will see that there is some space between the acromion and the head of humerus, which needs to be maintained throughout the range of motion. If this space is not maintained, there is a space. If this space is not maintained, and if this compresses like this, or it pushes against the acromion process, the head of humerus, then it creates a lot of impingement. The structures that come under the acromion usually will get impinged, and this will lead to impingement syndrome. And impingement syndrome can later on cause tears in the muscle, or they can cause a lot of tendinitis. Okay, so it is very important for us to have normal scapulothoracic motions in order to have a normal glenohumeral motions, which in combination will create a full range of normal motions at the shoulder girdle. And to next, we are talking about the clavicular movements. So during the elevation of the shoulder girdle, okay, we have the elevation of the scapula and there is a posterior rotation of the scapula. So when I do the elevation, the clavicle elevates upwards and it rotates posterior. When I bring the hand down, it comes to neutral position. When I do extension, right, the clavicle rotates anteriorly and it goes into depression. With abduction, there is again elevation of the clavicle. So what you see here is these are the axes that we have shown here. The dotted lines that you see are the axes of the motions for clavicle. So there are 6 motions. We have elevation, depression, retraction, protraction, and we have the posterior and the anterior or medial, anterior and the posterior rotations. We end for today's session. Thank you all of you for patiently listening to me.
We thank Dr. Dharmang. Thank you so much, sir.
Thank you, PhysioTV team, Sancheti Hospital, Sona ma'am, for inviting me as a resource person for this talk. Thank you so much, ma'am.